Now, warfarin, as we know, is a vitamin K, or sort of stops the action of vitamin K dependent clotting factors, but there are concerns because it can harm the developing embryo and fetus as well, and there are concerns in pregnancy as such. How does it work? It works on your VOCA R1, your vitamin K dependent epoxide reductase, and it prevents the activation of factors 2, 7, 9, and 10. But there are varying genes that control these drugs, including genes that control your CYP2, C9. Of course, there's chromosome 10, and then there's chromosome 16, and there are varying alleles for these for this drug, and its metabolism is one of great concern because not everyone is homozygous for these genes, and henceforth we have dose-dependent responses. So the embryonic concerns that we do have has been discussed, and it's basically in the first trimester from around 5.5 weeks to up to 12 weeks. But further on, there are concerns in terms of CNS development, and this has to be taken into account as well. And as you've heard of the concerns that we have, there are a multitude of concerns that can occur, but it just doesn't stop in the embryonic period, and this can carry forth. Is it dose dependent? Some say yes, less than 5 milligrams will have far less of an impact, but certainly there are reports out there that show that even at 5 milligrams or less, there are concerns. And if you look at the teratogenic aspects, and you've heard they can vary with a high miscarriage rate from anywhere 6 to 17%, and the miscarriage rates are as high as 40%. And when we've looked at a case of ours as well, where a patient came in with a mechanical valve that required anticoagulation, and she came in she booked late, and she had a poor outcome. And as you can see, that there was concerns in terms of CNS development, and these drugs can cause such major concerns and poor pregnancy outcomes. Now, for us, the big concern is valvular thrombosis, and nobody wants to see this, and it does occur in approximately 5% of pregnancies per se. The big concern here is that if you're going to give a drug, make sure that it's monitored in the right way. Now, there are 3 contemporary ways as to how we use anticoagulation. The one is vitamin K's or VKA antagonists throughout, low molecular weight throughout, or a combination of the two. And what needs to be explained is none of these strategies are without risk. They all have their own concerns. So we looked at our own data, and this was an MSc that came out that was published. And if you look at the spectrum of disease that we've seen, rheumatic heart disease was of big concern. And this is the prevailing thought. If you look at articles that come out from our country as such, this still plays a big role. And it certainly plays a big role in the patients that we see that do conceive. Work done by Mazibuko has looked at this from a natal perspective. And again, he's ascribed to finding something else in the anticoagulant regime strategy other than warfarin. Is there a way that we can circumvent this? Because you've got a patient who goes through pregnancy and she's got this valvular heart disease, you're giving her the drug, and she must be aware that sometimes the idea of taking home a live child may not be the case. In fact, if you look at the reports from the ESC guidelines, they say a patient with a mechanical prosthetic heart valve has only a 58% chance of taking home a live birth. So when I joined the department at Charlotte, we looked at using low molecular weight heparins in our pregnant patients with mechanical prosthetic heart valves. And of course, this was an MED that was published as well. And we first looked at a cohort of 15 patients. And the good news that we have is that from the study, we found that if one basically monitors the anti-factor 10A vigilantly, and you maintain it at between 1 and 1.2, the outcome of pregnancy can be very good. And that is seen by the fact that none of the 15 patients died. There were concerns with some bleeding postpartum, but we've certainly resolved these concerns, having more experience gained with what we tend to then do. But again, it's a multidisciplinary approach, and hematology is a great adjunct for assisting us, especially in the postpartum phase. Now, if you look at the choice of your drug that you're going to use will be dependent on the valve type, where the valve is. You know, it's a mechanical valve, it's in the mitral side of the heart. Is it on the right side of the heart? Was there previous concerns in terms of thromboembolic disease? Do you have the ability to monitor this drug? And that's the big thing. And what are the costs ascribed to your institution per se? And do you have access to these drugs? So these are the concerns that, or these are the things that you need to think about before prescribing the drugs. And then, of course, adequate monitoring is vital. And this has to be done for us from a mechanical heart valve point of view. It's done every week. And we tightly maintain an anti-factor 10A of between 1 and 1.2. And certainly we've had good results. Now, if you look at the world per se and what has come out, and if you look at the names of people who deal with this concept of mechanical heart valves, you get the work of Claire McClintock. And of course, she ascribes to it as being no easy task, which is not, because every patient is different as well. Dependent on where you work, your outcomes will be different as well, and dependent on your resources too. So when she looked at her work, or when she looked at what is out there, you can see in the slide that the work of Chitseke, the work that we did, comes to the fourth. And we've certainly had very good results. In the 15 patients, or that cohort that we had, thankfully, we had no maternal deaths, and the fetal outcomes were good as well. And there was no thrombosis of valves. If you look at the work by Rohan D'Souza as well, and looking at optimal anticoagulation, what is found is that your take-home baby rate was far better using heparinoid type drugs, and especially the low molecular weight drugs, as opposed to your VKAs. Now, what must be said is that VKAs seem better for mom, heparins better for baby. So it's a balance that one needs to reach. And in this balance, one needs to involve the maternal side in her own care. Mums have to also help you make this choice as to what they want. Again, if you look at the dosage of the drug, certainly 5 milligrams or less was not without its concerns, and there were still congenital anomalies ascribed. And that was because, or that is because of the vast gene array in different patients, and we're all not the same from a gene perspective, and the loci that are involved with the metabolism of these drugs. If you go through again, he looked at a meta-analysis, and what was found was that similar things, less than 5 or greater than 5 milligrams are of concern. Yuri Alkayam comes forth and says, how do we make this safer? And they ascribe also to the use of low dose of aspirin, which we don't do. But again, the prevailing thought is you've got to involve your patient in this care. The ESC guidelines again, and if you look at the ROPAC registry, which they ascribe to, and as I've said before, mechanical valve patients or patients with mechanical valves are at a disadvantage in terms of their disease state, but also because of the drugs that they tend to use. And if you look at the UK, if you look at the UCOS study that came out in 2016, they had very dismal results, and they had a high maternal morbidity and mortality rate that approached 41%. Coupled to that was a high perinatal morbidity and mortality within the same percentage range. And they actually said that it was, their monitoring was not the best. It wasn't, patients weren't monitored strictly at a place where it could be done. And these were the concerns that came to the fore. Now, also ascribed to this was the fetal loss rate, even with the combined approach where you're using heparin and warfarin. And the best results, again, were obtained when low molecular weight was used throughout. So in summary, then, what they say is that VKAs are of concern because of the anomalies that can result from using this drug, and nobody is really immune from its effects. From the ESC, they don't believe that low-dose aspirin has any benefit, and it may just increase the bleeding risk. Now, the latest, if you look at the guidelines from 2022, and if you look at the work from Catherine Nelson-Piercy, they tend to want to use aspirin, and they tend to say that one should involve your care should incorporate this. And there's a paucity of data to say what is really the right thing to do or to use. But again, they come forth strongly and say that vitamin K, again, or your VKAs, vitamin K antagonist drugs are better for mom, heparin's better for baby. But we've got to find this equivalence point, and it involves maternal care as well. And factors that are involved in the thrombosis, as we've said before, and thromboembolic disease state is the mechanical mitral valve, the valves on the right side of the heart, if there's atrial fibrillation, of course, and a previous thromboembolic event and multiple mechanical heart valves. Now, in our work, we've certainly looked after patients with multiple valves, and we've not seen the concerns that is ascribed to. And again, it's basically balancing the benefits and the risks, but again, involving your multidisciplinary team and your patient as well. What does Catherine Nelson-Piercy ascribe to is that one can give patients the choice in the first trimester, but certainly from around 5.5 to 6 weeks, one should think of switching to low molecular weight subcutaneously in a twice-a-day dose to try and reduce the risks of this of the concerns. And there's talk of less than 5 milligrams being better for embryonic outcome. But then again, patients have to make the choice. During the second trimester, we tend to use low molecular weights throughout as well, and we monitor the anti-factor 10As. We don't discriminate between the valves, and we maintain a strict 1 to 1.2 anti-factor 10A activity, and our outcomes seem to be good. We do not use any aspirin at all. When it comes to approach to a planned birthing, there's the rule of 12 to 24 hours, but we tend to stop our low molecular weight for 24 hours, and we induce our patients, and our outcomes have been good. What is described is that once you induce your patient and you're approaching the 24-hour mark, what do you then do? What is described is one can use half the dose of the drug that you've given in terms of the dose that you've given. Half of that can be used, but then again, you've got to wait 12 hours if you're going to be having a spinal, or the anesthesiologist has to be sort of talked to about what you're going to do. And again, it's a team approach as to what you need to then do. We do not use any unfractionated heparins as a bridging, and we've certainly seen our results being good. But again, I'm only talking from our center per se. It's difficult to use your unfractionated heparin drugs because you've got drip sites which can cause or which can lead to SBEs. And of course, it's difficult to measure these APTTs. There's talk of doing or checking your anti-factor TNAs when unfractionated heparin is used, but we certainly don't do that, and I don't have experience with that. Now, in the postpartum phase, again, they tend to use 0.5 milligrams per kilogram of the dose that you've used, or certainly 0.75. And we've certainly done this, and we've had good responses. And then how do you bridge these patients? And it is said that because of your protein S, which really drops during your pregnancy and in the postpartum phase, one should wait before starting warfarin to bridge patients again. And we wait between 3 and 5 days before we start again. And once the patient has reached an optimal INR, once the drug has been commenced, we then stop our low molecular weight heparin drugs. Now, again, if you look at articles from the Maternal Fetal Medicine Society, they come with similar thoughts, and evidence is sort of grade 1B and grade 2C as to what can be done and what must be done. And again, it's all described to where you are, what you can use, what your availability is in terms of monitoring the drugs, prescribing the drugs, and follow up as well. And how should anticoagulation be performed is similar to what has been described. Described in the past. The change here is they talk about a trough, that is taking blood from the patient prior to the next dose. And we don't tend to do that. We concentrate on peaks. Now, to get a trough of what they describe as greater than 0.6, you may have to increase your dosages where to your peak 3 hours after your last dose would have to approach at times greater than 1.2. After 1.4, 1.5, one tends to get bleeding concerns. So one has got to be very careful when using a trough. There's some centers that do, but we don't. Again, best practice guidelines. When should you induce these patients? We tend to do it at 38 weeks, and not before that. Right, so without data, you're just someone who's got an opinion. What has our data shown? We've certainly looked after a cohort of 48 patients. With the 15 that we did in the past, there's 63 patients. And, thankfully, we've not had any maternal concerns. No mothers have succumbed or died. Our fetal outcomes when they're live births are good, but we've also seen a fair share of miscarriage states. And these patients tend to come later. They don't book early on. And these are the concerns that we have. So one of the big things in taking into account with cardiac disease is to have our preconceptual clinics where we can guide and strategize as to what needs to be done for the patients. And so in conclusion then, and take home, anticoagulation in pregnant patients with mechanical prosthetic heart valves is no easy option. You've got to weigh the risks and the pros and the cons between your heparinoid drugs and your VKAs, and there are controversial management options. With that, thank you.
Arun, thank you very much for a great overview of a very difficult topic. And thank you also for citing those different articles. I think there are many useful references that you showed us. And I also just want to say, I think the multidisciplinary approach is really great. And I'm very glad that you stressed that. There's just one comment in the chat box from Amelia Deity that said, considering the high prevalence of pregnancy losses due to teratogenic effects of warfarin, interventions are necessary to increase awareness among both patients and healthcare workers. And I see that Jacques has made similar comments as to the lack of awareness of the teratogenic risks of warfarin. So thank you both for those. I'm going to ask Jared to prepare or to share his screen so long while we hear if there are any other questions. But while we're waiting, maybe just two general comments from my side. One is that always keep your eyes open for new guidelines in venous thromboembolism, both inside and outside of pregnancy, because these things are, there's a lot of research ongoing around the world, so these things are relatively frequently updated. And I'm sitting with the latest one, as a matter of fact, is printed out on my desk. I think it's really useful to have those things at hand. And then just a very practical point from my experience working a lot with surgeons in private practice. I was often asked by surgeons to help them look after patients, and patients then have to go for procedures, but they're all supposed to be on prophylactic Clexane or whatever low molecular weight heparin. I'm going to use Clexane as the example now because the half-lives might be different. And just from a very practical thing is that I would recommend is if you're only giving a single daily dose, prophylactic dose of Clexane, give it in the evening. That will make your surgeons very happy because you need about 13 hours for that Clexane to be out of the system so that they can cut. And if your Clexane is prescribed for the morning, you will not have a very happy surgeon or anesthetist if they receive the patient in theater and see that the patient has just had a dose of Clexane at 7 o'clock or 6 o'clock in the morning. So it's a way to make your own life a lot easier. And I found that very practical. Evening dose of Clexane, that really helps a lot. Great. Our next speaker, and please, if you have any other questions for Arun, please put them in the chat box. Just because in the interest of time, I'm going to move on now. Dr. Jared Samparini is a specialist physician, as you can see there at Charlotte Masheke, Johannesburg Academic Hospital, and works at Wits. He obtained his MBCHB degree with distinction, and he's got a Master's of Medicine in Internal Medicine, as well as a diploma in HIV management, and is currently a consultant physician at Wits. Jared, you're going to speak to us about bleeding disorders in pregnancy. Thanks for taking on this important topic, and we look forward to your talk.
Thank you, Prof. Thank you for having me today. I'll just, these are my disclosures. Oh, is it moving on? These are my disclosures. Just another disclosure, Prof. Lowe examined me for the FCP. So if everything I say is rubbish, it's because you can blame him for giving me my FCP as well. But on to serious things. Why are bleeding disorders in pregnancy important? Some of you may have seen this. It is from the most recent report on confidential inquiries into maternal deaths. So looking at the maternal mortality rate in the country. So if you look over here, obstetric hemorrhage accounts for the third most common cause of maternal death in the country, ranging from the most common in Mpumalanga to the fourth most common in KZN, Gauteng, and the Western Cape. Now, the majority of these cases of obstetric hemorrhage followed vaginal delivery, and they were due to uterine atony or retained placenta. But a significant proportion were due to an unspecified PPH. Now, if we have a look at this data from the United States, about 1 in 500 deliveries when there's PPH is due to a coagulopathy. So basically accounting for less than 7% of postpartum hemorrhage in the United States. Now, this is a small number, and while bleeding disorders probably don't cause a lot of obstetric hemorrhage, what we do know is that 90 visits there, the confidential inquiries report, but you have to wonder how many of these deaths could have been prevented if there was maybe an underlying bleeding disorder that developed or that was inherited, that was missed at some point during the pregnancy. So what you need to ask yourself is, where is the problem? And when there's bleeding, as I said to the obstetricians yesterday, I'm a physician, and when there's bleeding, this is how I feel. I haven't crossed the red line into theatre in close to 10 years, and I'm happy to keep it that way. But the best way to think about it is, where's the problem? Is it the platelets or is it coagulation? And if we look at platelets, think, is this a thrombocytopenia or is this platelet dysfunction? Or as I like to think about it, are they low platelets or slow platelets? If they're low platelets, think about, is there increased destruction, decreased production, or other? With increased destruction, as you all know, the problem is peripheral. And this could be an autoimmune ITP, so occurring de novo in pregnancy, or due to another underlying autoimmune disorder. Drug-induced ITP, important drugs in obstetrics, antibiotics such as ampicillin, rifampicin in our patients with TB, and then something that obstetricians prescribe on a weekly, if not daily basis, methyl dopa for pregnancy-induced hypertension. And also think of things like Bactrim that some of our patients may be on. Chronic liver disease and hyperstenism, acute fatty liver of pregnancy, not very common, but an important cause to look into. And then your microangiopathic hemolytic anemias, help in preeclampsia, every obstetrician's bread and butter. Don't forget DIC and then TTP. If you're looking at decreased production, the problem's in the bone marrow. Now, these causes are less common in pregnancy, so your B12 and folate deficiency, aplastic anemia, leukemia, and then drugs. And again, these drugs are not very commonly used in pregnancy. And then, of course, your other causes. And the most important is gestational thrombocytopenia, but bearing in mind that almost by definition, the platelet count does not drop below 70, and these patients tend not to bleed. But important cause to think of if your platelets are low. If there's platelet dysfunction, so your slow platelets, the inherited causes are rare. I'm not going to go into them, but then think of your acquired causes. So drugs that are given, so aspirin, NSAIDs, and then any other organ failure. So liver failure, cardiac failure, renal failure. But of course, I think your platelet dysfunction is probably the least of your problems if you have a whole bunch of organ failure. Although having said that, I'm speaking to hematologists, so you probably feel that the platelet dysfunction is the most important. In terms of coagulation, is it acquired or is it inherited? So if it's acquired, think of DIC. It's a really important topic. I would have liked to have spoken about it, but I think time is short. Acquired inhibitors, so usually factor VIII, and as you know it's associated with rheumatoid arthritis, SLE, malignancy. It could be drug-induced, but an important cause of acquired factor VIII inhibition is with an unknown reason, but it can occur postpartum, more commonly in primigravidas. And this is about 1 to 4 months postpartum that it can happen. And then obviously less commonly inhibitors of the other factors. One to remember is factor II, that's associated with antiphospholipid syndrome. You acquired von Willebrand disease, less common than the inherited form, but associated with common diseases such as hypothyroidism. And then anticoagulation. Have we caused the problem? Did we give the warfarin? Did we give the Clexane? As Prof. Elise said, we don't use DOACs in pregnancy, but are we the reason for the coagulopathy? And then your inherited causes. So hemophilia, von Willebrand disease, and then factor XI deficiency, which is rare, but it has a fairly common prevalence amongst the Ashkenazi Jewish population, about 8%. And a lot of the South African Jewish population are descended from Ashkenazi Jews. So something to just bear in mind. So it leaves you with this. It's bleeding, platelets, coagulation, and then all of your different causes. Of course, when there's pregnancy involved, you have to ask, how is pregnancy affecting the disease? So how does pregnancy physiology affect hemostasis? Again, think to your platelets, think to coagulation. The platelet count drops in pregnancy. This is a fact. We all know about this. And if you have a look at this from the NEJM in 2018, median platelet count in non-pregnant women up to there, and then dropping at the time of delivery, and then back up postpartum. And just the actual numbers, median platelet count of 273 versus 251 down to 217 in singletons, and a bit lower in twin pregnancies, and then coming back up to baseline at postpartum period. Now, by definition, a thrombocytopenia, so less than 150, has a prevalence of between 6.6 and 12% at the end of pregnancy. But counts of less than 100 are only seen in about 1% of women. And that's why this value is the value used when you're considering true thrombocytopenia in pregnancy. Now, when you switch over to the coagulation side, there's a fine balance between clotting and anticoagulation. But in pregnancy, this changes. There's an increase in your coagulation factors. So 2, 7, 8, all go up. There's an increase in von Willebrand factor. I'll ask you to remember this because we'll talk about it when we discuss von Willebrand disease. There's a decrease in protein S, protein C stays the same. There's a decrease in antithrombin levels of up to 20%, only starting to pick up about 12 hours post-delivery. Some studies do say that there isn't a decrease in antithrombin, but the majority of experts feel that there is definitely a drop in your antithrombin levels. And then there's a decrease in fibrinolysis due to an increase in your fibrinolytic inhibitors. So where we're normally sitting here, everything is skewed towards clotting, and pregnancy is a prothrombotic state. And this obviously happens for a reason. And that reason is that it prevents excessive hemorrhage during your placental separation. So we've looked at the causes, we've looked at the physiology. I want to just touch on the two inherited causes of bleeding disorders. The first one being von Willebrand disease. Now, again, as hematologists, as you all know, and I'm sure a lot of people who aren't hematologists maybe think back to medical school, what your von Willebrand factor does, it's a protein that facilitates platelet adhesion. So when there's vessel damage, it binds to this exposed subendothelial collagen and GP1B receptors, and then it facilitates platelet adhesion, causing primary hemostasis. But what it also does is it prolongs the half-life of circulating factor VIII, and then it delivers it to the sites of vascular injury, aiding with secondary hemostasis. Now, it's the most common bleeding disorder, about 1.3% of the population, but it's probably severely underdiagnosed in South Africa. Only 632 patients in the country had von Willebrand disease, according to a 2016 survey. Now, if you're quick at maths, 1.3% of 60 million is 780,000. So somewhere along the way, something isn't adding up. There are three major types, with either quantitative or qualitative deficiency in von Willebrand factor. Type 1 is the most common. Up to 80% of patients with von Willebrand disease have type 1 disease. It's a partial quantitative deficiency, so your levels are 5 to 30% of normal. Type 2A, about 15 to 20% of patients. There's a decrease in von Willebrand factor dependent platelet adhesion. So your levels may be normal, they are invariably a bit lower, but there's a problem with that von Willebrand factor platelet interaction. And then type 3 is a complete quantitative deficiency. It's one of the more rare types. And then type 2B, M, and N are rare, but I draw your attention to type 2B because in pregnancy, these patients can develop a thrombocytopenia. And if you give them DDAVP, they definitely will develop a thrombocytopenia. So how do these patients present? In the obstetric setting, they may give a history of menorrhagia, but then also your classic epistaxis, easy bruising. After dental extractions, they have excessive bleeding. Antenatally, your type 1 patients do pretty well. As I said, your levels of von Willebrand factor go up. Your type 3 patients, they may have bleeding. There isn't an increase in the levels of von Willebrand factor in them. And your type 2Bs have worsening thrombocytopenia. And then postpartum, there's an increased risk for postpartum hemorrhage. So what you need to do for these patients, you check your activity at booking 28 and 34 weeks. And before any invasive procedures. So if you're going to do an amniocentesis or if you're going to deliver this patient, then you want to check your von Willebrand factor activity. What I can't stress enough is your MDT input. Your obstetrician will take the lead, but you need your anesthesiologist involved. What's the plan for anesthetic? Is this going to be neuraxial? Does this need to be a general anesthetic? Your hematologist and physician working together, to guide the management. And then don't forget your genetic counselor and our pediatric colleagues, because this really does impact the baby and you need them involved. And then just note the units. As you know, we use percentages in South Africa, but some international literature will use international units per deciliter or per mil. So if your activity is less than 50% and you're planning an invasive procedure and you're type 1s, you can give DDAVP. As you get, when you give DDAVP, there's release of von Willebrand factor, and then you have an increase in your levels. Type 2s, you can do a trial of DDAVP. Ideally, you will have wanted to do this pre-pregnancy to see if it works, but not in your type 2B patients. And then type 3s, it's ineffective. There's nothing to start with. You're not going to stimulate any release. Tranexamic acid is useful in all types of von Willebrand disease, but in your type 2s and 3s, you probably will need von Willebrand factor concentrate. In our setting, we would use hemosolvate, which has factor 8 and von Willebrand factor in it. In terms of neuraxial anesthesia, the consensus, or there is some consensus, that neuraxial anesthesia is safe provided your activity is more than 50%. But on the flip side of that coin, and what a lot of people argue, is that your type 3s, you're never going to get their levels above 50%. So is it safe to do it? And your type 2s, even if the levels are above 50%, is that von Willebrand factor any good at doing its job? So the other side of the coin, a lot of people will say, don't give neuraxial anesthesia to your type 2s and 3s. What is agreed is that vaginal delivery is safe, but you want to avoid vacuum and forceps. And a discussion I had with some of the obstetricians yesterday is the problem with vaginal delivery is that you might get to that second stage and you're stuck and you have to do assisted delivery. And then what do you do? So there is some debate whether Caesar is better, but for the most part, guidelines recommend Caesar for obstetric indications. Now, postpartum, there's a risk of PPH, both primary and secondary. And the average time to postpartum hemorrhage is actually between 11 and 23 days. So these patients are home for 2 weeks before they actually hemorrhage. So as obstetricians, it's important to, when your patient phones and they're bleeding 2 weeks later, try and see what's going on. Avoid aspirin and NSAIDs in these patients. And then your tranexamic acid can be used for 3 to 5 days, depending on mode of delivery. DDAVP with caution, that's because of the fluid shifts postpartum. And then oral contraceptives can also be considered. They are useful for getting your von Willebrand factor levels up. But essentially, you want to maintain your levels above 50% for 3 to 5 days, depending on your mode of delivery. So we're going to move on to hemophilia. X-linked disease, as you know, affecting either factor 8 or factor 9, with hemophilia A about 3 times more common than hemophilia B. Now, here we have a little genogram. So this chap over here has hemophilia, and they have 2 kids, and the daughter is a carrier because she gets the affected X chromosome from dad. She then goes on to have her own kids, and as you know, a hemophilia carrier, 50% of her sons will have hemophilia, 50% of her daughters will be carriers. Now, hemophilia is a disease of male patients for the most part, so why do we have to think about it? Well, there is still a risk for bleeding in females with a family history of hemophilia, so, hemophilia carriers. The one reason is you could get heterozygote females. So dad has hemophilia, mom's a carrier, and you're unlucky to get 2 affected X chromosomes. Lionization, so there's extreme degrees of X inactivation. But the most important is that there are varying levels of factor activity in carriers. Now, if you have a look at this article from Blood in 2006, in the 225 hemophilia carriers, the mean or the median clotting factor activity was about 60% versus 100% in your 143 non-carriers. And this drops as low as, you can see, about 5 to 10%. And as we know, if it's less than 40%, you bleed on major hemostatic challenge, and less than 1%, it's severe and you bleed spontaneously. So your hemophilia carriers, as much as they don't have hemophilia, they are still at risk of having low factor activity. So how do we manage these patients? Well, antenatally, again, I can't hop on about it enough, but get your MDT input early on. Get the whole team involved to plan this patient's pregnancy and delivery. Check your factor levels at booking 28 and 34 weeks in terms of hemophilia A, but just at booking in terms of hemophilia B, because you're not going to have an increase in these factor levels. Determine the fetal gender early on, so either by ultrasound or if you have available cell-free DNA, to determine, is this a male fetus? Because if the fetus is male, you can offer prenatal diagnostic testing, or you can manage as if the fetus has hemophilia. And what that means is you want to avoid invasive fetal procedures. You want to avoid forceps or vacuum delivery. And if fetal procedures are needed, then you want to determine the risk benefit, and whether you should go ahead with this procedure. There is a debate about the best mode of delivery. These articles appeared back to back in Hemophilia in 2010, with this crowd saying, vaginal delivery is the best, this gang saying cesarean's the best. The vaginal delivery guy said, if you have a look here, NBD, there's the same rates of subgaleal, intracranial, umbilical hemorrhages. The cesarean team then said, hold on a second, in hemophilia, 4% of infants delivered vaginally will have serious injury versus 0.6%. Then the vaginal sort of side said, hold on, the risk of bleeding in a neonate is 2 to 4%. It's not that bad. The CSER guys argued back, well, there's an increased risk for cerebral hemorrhage. CSER allows for controlled factor administration. So there isn't any consensus. What is agreed upon is that you want to avoid operative vaginal delivery and avoid fetal scalp sampling or electrodes. So delivery, if your factor levels are less than 50%, you want to give factor replacement. You could use DABP and hemophilia A. And then neuraxial anesthesia is safe if your factor levels are more than 50%. Postpartum, maintain your levels above 50% for 3 to 5 days, and some would consider the use of tranexamic acid. So that brings me to the end. My take-home points. Bleeding disorders are varied. They range from common to rare. Always think platelets and think coagulation when your patient's bleeding. Where is the problem? And then involve the whole team early on. Get the obstetrician involved, hematologist, physician, anesthetist, pediatrician. And then don't forget your genetic counselor. They are an underutilized service, and we really should be getting them involved in these patients. Thank you so much.
Jared, thank you very much. I think you've just shown that our judgment at the college exams was great. Well done. And secondly, I think you should just come and specialize in clinical hematology, if you're not already planning to do so. Thank you very much for that overview. So you'll see I've put out a small challenge in the chat box to ask everyone to maybe just share one thing that you're taking home today, or that you think you would like to go and share with someone else. In the chat box, Jacques Malherbe has already made a comment there. Have a look, put something in. And then while you're doing that, just a reminder that the link for CPD points is open. There's a link in the chat box that you can click on. You need that meeting code for the day, 27. And also take note of next week's talk, which is going to be very important. Prof. Sean Wasserman will speak on resistant gram-negative infection, something I'm sure all of you deal with every single day. Big issue for us in the transplant unit, etc. And please invite your local microbiologists, antibiotic stewardship teams, and infectious diseases teams. Sean works very closely with us at clinical hematology and has got huge experience with heme patients. So I think you're going to enjoy that. If you have any questions for Jared, please add that too. But I've got a question here for Haroon. Great talk, Haroon. Can you take us through how your unit bridges patients back onto warfarin post-delivery? And just a comment, excellent presentations by all today. Thank you. So that's in prosthetic heart valves. Haroon,
thanks, Prof. Yes. Now,
great.
What I do find is that this topic has to be taught and has to be reinforced. Now, once the patient has birthed, you now have your patient where the pregnancy changes have somewhat now resolved. The increased renal blood flow has changed, the volume of fluid has changed, but there also are concerns, as I've showed, in terms of the anticoagulation profile of this patient. And the concerns remain or occur within the first hour and then within the first 24 hours. So what we do is we half the dose of the Claxane that we did use, and we then monitor that. We tend to do an anti-factor 10A 24 hours afterwards. And only after 3 to 5 days do we add warfarin then at 5 milligrams, and then taper that up if we need to, taking into account the INR on day 3. So we work closely with our hematological team, and we sort of call upon the PI clinic to come along and assist as well. And this is how we tend to bridge our patients, but taking into account that they are at risk for PPH. And certainly if we do it this way, we seem to have no concerns in terms of postpartum bleeds. And when we bridge them, or when we bridge it from day 3 to day 5, we seem to have good responses. And that's is what we tend to do.
Great, thanks so much.
Answer.
Thank you for that very comprehensive answer. Appreciate that. Elise, can I ask you maybe to come back online again and maybe hear from you if you have any final closing comments. I just want to also say thank you to all 3 our speakers for your very didactic style talks. It was really easy to follow, and I could see that a lot of effort went into preparing them. Thank you very much. And while we are here together, I just want to say a special congratulations also to Dr. Yusra Kheer from the Sudan. She was a supernumerary fellow at UCT and recently heard that she passed the college exams. Well done, Yusra. Very proud of you. And I'm not sure if we mentioned some of the others before, but I was just seeing Yusra here in the room now. There's a lot of positive messages in the chat box. Everybody can have a look there. Thank you for those. Elise, I'm going to leave the closing words to you, and then I wish everyone a wonderful Monday night. Until next week. Elise?
Thank you kindly to my colleagues, Dr. Rematula and Dr. Zamperini. We work together to run the obstetric cardiac hematological clinic. And I hope you all enjoyed the session this afternoon. Thank you.
Thanks, Elise, and drive safely. Sorry that I put you on the spot there. And until next week. Bye-bye, everybody.
Thank you, Prof. Bye, everyone.
Yes, Prof. Thank you.
Thank you, Prof.